Inflammation, it is defined as a complex reaction. It is a biological response which is being elicited by the human host immune response to which is protective in function when there is any insults or exposure to foreign bodies. So it is defined as a complex reaction to injurious agents. It could be such as microbes or otherwise any damage which usually includes necrotic cells, and these cells that consist of vascular responses and migration and activation of leukocytes, as well as which also includes certain systemic reactions. So this defines inflammation. And coming to the agents which usually cause inflammation, they are the infective agents. It could be of microbial origin, which could be fungal, parasitic, bacterial, or otherwise viral agents, which usually elicit the inflammatory response by the human host system. Next, coming to the immunological agents, they could be activation of the cell mediated or otherwise humoral mediated body response to any exposure to foreign bodies. It could also be because of certain physical agents. They could be inorganic or organic poisons. Next, coming to the physical agents, they include usually any insults for the thermal or cold or otherwise any presence of irritant or any injuries. Then there includes the chemical agents, that is the organic or inorganic poisons. Then the inert materials, they are the foreign antigens. Next, coming to the cardinal signs of inflammation, which was being introduced by Virchow in the year first AD. So based on certain features of the inflammation, that is the most important 5 features which are usually observed in any inflammation, that is the redness. So he has been termed it as rubor. Then coming to the swelling, that is increase in the size of the area undergoing acute inflammation is the tumor. Then comes heat, that is there's a rise in the temperature at the area of the acute or otherwise the chronic inflammation. It is known as scala. Then pain, which is being elicited by the patient, it is known as dolor, and loss of function is known as functionalesia. So these are the cardinal signs of inflammation. Next, coming to the cells which are usually involved in inflammation, they are all these cells which include polymorphonuclear neutrophils. They are the first line of cells usually which are seen in acute inflammation. They are the major number of cells which are usually seen in circulating blood, which constitute of more than 40%. And they are known as polymorphonuclear because of the presence of the morphology of the nucleus. And these neutrophils usually have serve functions in the ongoing process of inflammation. That is, they interfere but with the help of certain granules, as PMNs store certain granules within them, and these granules usually are released when these cells are sensitized or once they get activated by getting adhered to the endothelial membrane at the damaged site. Then these PMNs get activated and they are involved in releasing the granules, which of these granules usually aid in adherence of the neutrophils or the leukocytes or the white blood cells to the endothelial membrane, and they start showing the biological response by moving or escaping out of this endothelial membrane, and they show chemotaxis, which is a attraction of the microbes to the cells to get them phagocytose, that is get them degraded by the process known as phagocytosis, which is cell eating, that is destruction of the microorganisms. So this serves the function of PMNs in inflammation. Next line of cells are the eosinophils, which are structurally and morphologically similar to PMNs, but they are few in number in the circulating blood. And these eosinophils, they are similar as PMNs because they also have the enzyme similar to that of neutrophils known as myeloperoxidase, which usually helps in bactericidal killing. And this myeloperoxidase is usually rich in eosinophils when compared to PMNs. Next line of cells are the basophils and the mast cells. These are the cells usually which contain certain receptors, that is known as immunoglobulin E receptor, which is a part of an immunological mechanism. This immunoglobulin E receptor, when it is being sensitized, that is when it gets activated by on exposure to an antibody, then these receptors they sensitize the cell, that is further they cause the degradation of these mast cells, and these mast cells or the basophils, which contain granules which contain heparin and histamine, they also act as a mediators of inflammation, as histamine is a vasoactive amine, that is helps in causing the producing the action of vasodilation. Next line of cells are the lymphocytes, which are the next predominant cells in the circulating blood after PMNs. These lymphocytes also serve in the function of adherence of the leukocytes to the endothelial membrane and causing the chemotaxis and phagocytosis, as well as degradation and killing of the microbial organs or the foreign antigens which have entered into the human host system. Coming to the plasma cells, they are morphologically distinct cells. When observed under a microscope, it is easy to distinguish plasma cells because of the presence of its eccentric nucleus with a chromatin wheel pattern, or which is also known as cartwheel-like pattern, because of the extensions of the chromatin, which gives an appearance of a cartwheel. So plasma cells also serve a function. Usually these plasma cells which are being produced by the B lymphocytes, they help in they also mediate the production of the antibodies which help in protecting the host immune response by mediating the process of inflammation. Next, coming to the mononuclear phagocyte system, these are the monocytes which could be circulating, or otherwise they are the tissue macrophages. These monocytes in the circulating blood, they constitute about 2 to 4%, and once these monocytes reach the tissues, they are known as macrophages, and these macrophages are usually involved in removal of the or the debridement of the a damaged area in the body. So these macrophages, they are the second line of cells in acute inflammation after PMS, but whereas in chronic inflammatory response, these are the first line of cells. So these, since neutrophils, they have a lifespan of only 1 to 2 days, that is 28 to 48 hours as a function, and they are being further being destroyed by the own host immune response. If the PMNs which are not being destroyed after 1 or 2 days, these neutrophils at the site of inflammation or at the site of injury, they are further being removed by the macrophages. So these are the monocyte phagocyte system. And coming to the giving an example of tissue macrophages, they are the histiocytes in connective tissue or the alveolar macrophages in lungs. Coming to the giant cells, when the macrophages usually fail to remove the microbial organisms which are harmful to the host immune response, then these macrophages, usually 2 or 3 of them or more than them, usually fuse together and result in a formation of multinucleate giant cells, and this is known as giant cell formation. Usually they are seen in conditions of inflammation. They are also seen in conditions in normal human body system. That is a normally seen giant cells in the human body are the osteoclasts, which have a multinucleate structures within them. That is more than 1 or 2 nuclei are present within them, which are larger in shape. Other than that, trophoblast is seen in a developing embryo, and also megakaryocytes, which are seen in bone marrow, are the normal giant cells which are seen in every human being. Coming to the other inflammatory giant cells, that is the giant cells which are involved in inflammation, they are the Langhans type of cells. These are the cells usually seen in leprosy, tuberculosis, where we see that there's more than 100, approximately up to 100 nuclei where they are fused and they form a peripheral rim, which is being shown in the first picture. Next, coming to the foreign body type of giant cell, which is seen in tuberculosis, we see that these usually move towards the opposite poles and give a horseshoe type of appearance. Next, coming to the Tauton type, which is seen in xanthoma, where we see a vacuolated cytoplasm, which can be seen in the third picture. These are the giant cells of inflammation. Coming to the tumor giant cells, that is abnormal giant cells, which are usually found in benign or otherwise malignant tumor. Coming to the anaplastic tumor giant cells, which is a malignant feature which shows the presence of more than increasingly number of nuclei which completely occupy this cell. They are the anaplastic tumor giant cells. Coming to the Reed-Steenberg giant cells, which are the characteristic feature seen in usually in multiple myeloma. Reed-Steenberg giant cells, they are the giant cells which are usually seen in Hodgkin's lymphoma. They are the characteristic feature which presence of this Reed-Steenberg can help in the diagnosing of Hodgkin's lymphoma. And this Reed-Steenberg giant cells, it is usually morphologically characterized by the presence of binucleate appearance, where we see that the 2 nuclei fuse together and give an owl's appearance, or with a interconnecting nuclear membrane in between them. Next, coming to the osteoclast giant cells, which are usually found in tumors associated with the bone. There we see increased number of nuclei which are placed in the center, or otherwise which could also be dispersed throughout the cell, but this cell is larger in size. These are the tumor giant cells. Coming to the factors which determine the variation in the inflammatory response, they are the factors which could be involved by the organisms, that is the organisms which influence the inflammatory response, that is a type of injury and infection. Usually when this is a viral induced infection, we see in an illustration of HSV can be given, that is herpes simplex virus exposure results in formation of vesicle. Then if it is a staphylococcal infection or any bacterial infection, which could most commonly seen presence of boils. So this is a type of injury and the infection which is being manifested in a host. Next, coming to the virulence, usually this virulence usually usually varies. When coming to the Corynebacterium diphtheria, which have a 3 variant stages, that is a gravis, intermedius and mitis, we see that these have a their own virulence, but they have a varying amounts of virulence in the 3 different strains. So based on the presence of virulence only, its host starts showing the manifestations. Next, coming to the dose, it depends on the dose, that is the amount of the organisms present. If it is present in the colony, then the manifestation could be severe. If it is present in a singular, then it could be manifestation could be mild or moderate. Coming to the portal of entry, certain organisms based on their entry into the host only can cause infections. Amongst them, portal of entry is saying an example of cholera. When induced subcutaneously, it is not infectious to the human being, but on swallowing, on directly ingesting it, can cause the infection. This is an example of the portal of entry. Coming to the product of the organisms, like certain organisms have produced their effect, that is streptokinase being released by the streptococci and staphylokinase by the staphylococcal bacteria. These organisms also influence the inflammation. Coming to the factors involving the host, usually presence of systemic disease, it could be a diabetic patient or otherwise any hypertensive patient, may show a hampered or a rendered host inflammatory response when compared to the normal individuals. Next, coming to the immune status of the host, as inflammation is being mediated by certain immune mediated cells, and it could be because of the T lymphocytes and B lymphocytes. So inflammation directly or indirectly depends on the host immune response. So usually in immunocompromised patients, such as in AIDS patient, that is HIV patients, we see the presence of lower number of T lymphocytes, CD4 plus T lymphocytes, which are usually actively participating in inflammation. We see that in a immunocompromised patient, there's inflammatory response is not up to a complete marked level as that of in a normal patient. Coming to the congenital neutrophil defects, that is the neutrophil defects which could be morphological or in the functional changes, could also affect the process of inflammation. Next, decrease in the count of the leukocytes also affects the process of inflammation, since leukocytes serve a major function in eliminating the foreign antigens from the body. So site and type of infection tissue involved also matters, one of the influencing factors for inflammation, because in structures such as lungs and bones, we see that there's the presence of loose texture. So acute inflammation when it occurs involving these structures, it usually varies differently because of the texture or complexity of the tissue. So this is one of the influencing factor in inflammation. Coming to the local host factors, there could be presence of any infection, that is, or any superimposed infection in the inflammation can also hamper or render the process of abnormal inflammatory response by the host. Coming to the type of X-ray, that is, as there's escape of fluid from the endothelial cell membrane during the process of inflammation. We see that there's presence of serous type of X-ray, fibrinous type of X-ray, purulent or suppurative type of X-ray, or hemorrhagic or catarrhal. Coming in brief, giving an examples of these X-rays. Serous type of X-ray, it is an X-ray which usually resembles serum and it is watery in consistency, and this type of X-ray is usually seen in pleural effusion in case of tuberculosis, or otherwise in cases of burns we see a presence of blister formation, shows this serous X-ray within this blister. Coming to the fibrinous, as name itself suggests, presence of fibrin content of the fluid X-ray is usually high, and so it is known as fibrinous X-ray, and it is usually seen in infections such as pneumococcal infection or otherwise rheumatic pericarditis. Coming to the purulent or suppurative type of exudate, purulent means pus discharge. That is, it forms a creamy form. There will be formation of a creamy pus, which is associated in case of pyogenic bacterial infections, such as in abscesses as well as appendicitis. Coming to the hemorrhagic X-ray, that is, there is presence of vascular damage which results in presence of blood within this X-ray, and it is seen in acute hemorrhagic pneumonia in influenza. Coming to the catarrhal exudate, this exudate which is usually shows presence of surface inflammation of the epithelium, which produces increased secretion of the mucus, and it is most commonly seen in common cold. These are the types of exudate. Coming to the types of inflammation. Starting with acute inflammation, which is an inflammation which lasts for a shorter duration, and it is an inflammation which shows PMNs as the major cells which are involved as a first line of defense cells. Chronic inflammation which lasts for a longer duration, and it is a long-term inflammation, and which is characterized by presence of leukocytes as well as macrophages. Chronic acute inflammation is an inflammation where we see that in this kind of inflammation there are periods of acute exacerbations of the activity of this chronic inflammation. Next, coming to the subacute inflammation, it's the inflammation where we see that it is shows the features as well of acute as well as chronic inflammation. That is, it mediates both the types of inflammation. Starting with the acute inflammation in detail, it is usually defined as an immediate and early response to injury, which is designed to deliver leukocytes to the site of injury. So it is a response which occurs early, which is being elicited by the human host, and where leukocytes are usually driven to the site of this inflammation immediately, and most commonly involved cells are the PMNs. So two main alterations which we see in acute inflammation is the vascular changes and the cellular changes. These vascular changes usually involve the hemodynamic changes or otherwise altered vascular permeability, whereas in cellular events we see that there is exudation of the leukocytes, that is, the leukocytes move away out of the original position, and these once they move out, they start initiating the process of phagocytosis, that is, cell eating. So the hemodynamics, that is the normal vasculation which is being maintained by the host, trying to be maintained by the host. First, initially when there is an injury, we see that there's vasoconstriction which lasts for a few seconds, and this is known as transient vasoconstriction, which mainly affects the venules and less commonly the arterioles and the capillaries. This vasoconstriction which occurs in an immediate transient leakage, that is injuries, can be seen, and followed by this is next comes the vasodilation, which persists for a longer time, that is for few minutes, and it is a kind of delay type of a reaction where we see, and it also affects venules to a less extent the arterioles and the capillaries. Followed by this is next comes the elevation of the local hydrostatic pressure. This elevation of the local hydrostatic pressure is mainly because of as the blood vessels start expanding, that is, they vasodilate, there will be increased amount of blood which is being flushed into this blood vessels. Once there is increased amount of blood which is being flushed into the blood vessels, this results in elevation of the hydrostatic pressure. As the hydrostatic pressure is a pressure which is being exerted by the arterial end and the venular end, we see that there is alteration of the hydrostatic pressure when it starts expanding, when it starts flushing into the blood vessel. Next, coming after there's elevation of this local hydrostatic pressure, we see that there's fluid translation, that is this increase in the amount of blood, it starts moving out of the blood vessels, this is known as fluid translation, escape of the fluid out of the blood vessels. Then followed by the fluid translation is the slowing or status of the circulation, blood circulation. That is because of the this fluid translation follows by swelling. That is when this fluid escapes into the extracellular space, obviously there is increase in the size of that particular area, and this increase is known as swelling, as we have seen one of the cardinal sign which is responsible for this fluid translation, that is tumor, otherwise known as swelling. Next, coming to this, swelling is being followed by slowing or status of the microcirculation, that is increase in the amount of the blood hampers the hampers or renders the movement of the cells which are present in the blood, as blood is not only fluid but it is also constituted of cellular constituents. So the blood vessel starts getting stagnant at one area, and this finally increases the viscosity of the blood. This increase in the blood viscosity will attract the leukocytes to the endothelial cell membrane. That is known as leukocyte margination, and this margination is being mediated by certain factors, because as leukocyte margination not only is involved in movement of the leukocytes towards the endothelial membrane, but once they move towards the endothelial cell membrane, they get attached to this endothelial cell membrane, and this is known as leukocyte adherence. This leukocyte adherence is being brought about by certain adhesion molecules. They are the selectants, integrins, and intercellular adhesion molecules, or vascular cellular adhesion molecules. Among the selectants, they are the P selectants, E selectants, and L selectants. P selectants, which are the selectants which are being performed and stored within the platelets, and E selectants, that is the endothelial which are being activated by the endothelial cytokine activated endothelial cells, and the L selectants, which are being produced by the leukocytes. So these are the one of the adhesion molecules. Next are the integrins. Integrins, they, other than adhesion, also they are being present in certain cells, which inflammatory cells, which these are being these have an stimuli these the next set of adhesion molecules are the integrins. These other integrins have certain receptors which usually attract this adhesion molecule towards the surface of the receptors, and these receptors are present usually in certain inflammatory cells. Once the integrins get attracting towards these receptors, that is, they come and bind to the receptors which are present on the inflammatory cell. They mediate the further inflammatory reaction by causing the progressive adherence of the leukocytes to the endothelial membrane. Thus, these are the few adhesion molecules which are involved in leukocyte margination as well as adherence of the leukocyte to the endothelial membrane. Once these leukocytes get attached to the endothelial membrane, they are activated. These activation of the leukocytes, they release certain factors and the granules present within them, which causes a temporary gaps within the endothelial membranes, and this temporary gaps helps in escape of this leukocytes, or the movement of this leukocytes out of the blood vessel, and this movement of leukocytes out of the blood vessel is known as a process known as emigration. So that is completes the hemodynamics of acute inflammation. There has been an experiment being carried out by Lewis to show what happens exactly in acute inflammation with a simple experiment where using a blunt point, a scratch was being driven on the forearm of a patient, where they have seen first a red line. This is because of the vasoconstriction, followed by that surrounding the red line is a flare, which is because of the vasodilation, which could be progressive, and this vasodilation, which was also followed by that is flushing or translation of the extracellular fluid into the translation of fluid into the extracellular space, resulting in wheal, which is known as swelling, and which also results in redness and thereby changing the bringing heat to the area of inflammation. So there is a picture which demonstrates Lewis experiment. Next, coming to the changes, usually since the fluid movement within the blood vessel and the interstitial extracellular fluid is being maintained by two pressures, that is the intravascular hydrostatic pressure as well as the interstitial osmotic pressure. So maintenance of this flow balance between these pressures is important in cases of inflammation, but normally we see that there's intravascular hydrostatic pressure, which is in coordination with that of the osmotic colloidal pressure. This is the Starling's hypothesis. Starling's hypothesis usually explains why there's outward movement and inward movement. The outward movement is because of the intravascular hydrostatic pressure and the interstitial osmotic colloidal pressure, but whereas the inward movement, it is because of the interstitial hydrostatic pressure and the intravascular osmotic colloidal pressure. This explains the Starling's hypothesis. But whereas we see that in inflammation, this is being altered, that is the pressure at the arterial and the venular end, that is hydrostatic pressure is being altered, where we see that there's increase in the intravascular hydrostatic pressure, which helps in flushing of this fluid or the translate out into the extracellular space and resulting in decreased colloidal osmotic pressure, which results in edema, that is flushing of the fluid into the extracellular space. This is a picture representing the fluid exchange in the inflammation. Coming to the differences in transudate and exudate, since we see it is one of an important sequence in the swelling or in the inflammatory area, it is important to know what fluid is usually being usually causing this swelling or the tumor, one of the cardinal sign of inflammation. This fluid could be a transudate or an exudate. Transudate, it is so called when there is no proper vascular changes in the vascular endothelial permeability, and this transudate, it is usually non-inflammatory origin and it is similar to that of the blood plasma level. There are no much changes in the concentration with that of the blood plasma level, and the pH, it is also alkaline in pH. But whereas we see in an exudate, that we see it's an inflammatory exudate which could contain pus cells or a gland. The cells which form the granulomatous or otherwise the inflammatory cells we find, so it is known as an inflammatory edema. And this is usually since it requires increased space to move out of from the intravascular area to the extracellular space, there's increase in the vascular permeability, and the pH also is being altered because of the presence of the other inflammatory cells, and these inflammatory cells contain certain granules and which usually constitute the enzymes or the structures which bring the damage in the microorganisms. So the pH is being altered and it usually gives an acidic pH of below 7.3, and usually the glucose is usually low when compared to that of the transudate. We see that the transudate usually this presence of this being stimulated by the mesothelial cells as well as by the cellular debris, and whereas the exudate, it is inflammatory cells as well as the parenchymal cells. And transudate, it is seen in congestive cardiac failure when there's presence of edema in these patients, whereas exudate we see in purulent exudate, that is in case of pyogenic infections. This is the difference of transudate as well as exudate. Next, coming to the mechanism of increased vascular permeability, we see the first changes we see is a contraction of the endothelial cells, that is endothelial cells get contracting, that is as alteration in the change of this endothelial cells. Followed by this, it could also be because of the retraction of endothelial cells, which is actually a rare process, which is only an in vitro procedure. Only in in vitro conditions they have observed this retraction of the endothelial cells. Otherwise, this vascular permeability could be also be increased either because of the direct injury to the endothelial cells, which bring about gaps or changes in the membrane. Then coming to the endothelial injury, which is being mediated by leukocytes, that is the leukocytes, because of the presence of certain granules or their specific composition, might also bring temporary gaps between these endothelial cells, which help in immigration of this leukocytes. Next, coming to the leakiness in neovascularization, as the capillary bloods are newly formed and not properly adapted yet to the mature blood vessels, there are certain gaps and pores in between this neovascularization, which brings about leakiness. Coming in detail to vascular permeability, vascular permeability could primarily occur because of the gap due to the contraction of the endothelial cells. As endothelial cells have property to contract for few fraction of seconds because of the presence of actin, so because of that, a gap is being created for a few fraction of seconds, which could result in the alteration in the vascular permeability. There is one of the reason why the gap occurs in a endothelial cells. Coming to the retraction of the endothelial, and this gap due to contraction of the endothelial cell, it is seen in mild injuries or thermal burns or any kind of very mild injury exposure. Next, coming to the retraction of the endothelial cells, which is only occurs in an in vitro experimental studies only, but in a normal being it does not occur. And this retraction, which is usually being followed by contraction, this might create a temporary gap within the endothelial cell. Next, coming to the direct injury, it could be because of either any mechanical injury or any kind of trauma, presence of irritant, which might bring this direct damage, which might bring damage to the endothelial blood vessel by creating gaps. And this injury can also result in increase in the vascular leakage when if suppose the gap is being created by direct injury, and it is more effective when compared to that of the other mechanisms of altered vascular permeability. The next coming to this next is injury, endothelial injury by the polymorphonuclear neutrophils. As a polymorphonuclear neutrophils, when they move towards the when these neutrophils move towards the margin, that is, as we have seen in hemodynamics, that is leukocyte margination can be seen at the site of inflammation. Once they move along the neutrophils move along the endothelial membrane, and at one particular situation, one particular position, these endothelial these PMNs get attached to the endothelial blood vessels. Once they get attached to the blood vessels, they start showing their action by releasing certain enzymes, such as lysosomal enzymes, otherwise myeloperoxidase, which bring about degradation of this endothelial blood vessel and help the movement of the leukocytes or the neutrophils away from the presence of the blood vessels. So this is one of the mechanism which brings about altered vascular permeability when it is being injury being created by this PMN cells. Next, come in cases of new vascularization. When there are new capillaries being found in an inflammation, it could be probably say in a granulomatous inflammation or chronic inflammation, and rarely in conditions such as acute inflammation, we see that since the capillaries are not yet fully developed, they have certain pores or certain gaps between them, and this gaps brings about the leakiness and alteration in the vascular permeability, and this occurs under the influence of vascular endothelial growth factors and other growth factors which are involved in producing the neovascularization. So this is a alteration of the vascular permeability and the mechanisms which are being carried out for the leakiness in the vascular permeability. Next, coming to the cellular events, it majorly includes exudation of the leukocytes, that is movement of the leukocytes away out of the blood vessel. And next coming is, once the leukocytes move away, they start showing the effects of phagocytosis, that is in debriding the area from microorganisms or foreign antigens. Coming in detail for the leukocyte exudation, it is followed out under certain sequences, that is first includes a margination, rolling and adhesion, and then next followed by this is diapedesis. Margination, rolling and adhesion, that is the leukocytes, they marginate towards the endothelial membrane, they move along the endothelial basement membrane, find a particular site where they get attached to it, that is as adhesion of the leukocyte, and if along with the leukocytes, if there is movement of even the blood vessels, then this is known as diapedesis, that is transmigration across the endothelium. Then once they migrate toward a usually it is this migration of this leukocytes is also mediated by chemotactic stimulus, that is the chemical mediators also known as chemokines, and this migration is brought about this chemokines. The leukocyte exudation, there is a histopathological picture showing the presence of accumulation of the blood vessels, blood cells and the leukocytes, starting with the migration, that is movement of the leukocytes towards. Initially we see that there is a normal axial flow, that is this axial flow is maintained by a proper sequential placement of the blood cells as well as the plasma cells and the neutrophils, which are placed in the central seam of the blood vessels. Surrounding this is a blood cell-free zone, and this is being seen within a blood vessel. So because of the alterations which are being seen in acute inflammation, that we see that there's when the vasoconstriction we see, or otherwise in a fluid translation we see that the alteration of the cells, that is they do not maintain a proper sequence, and rather these leukocytes move towards the endothelial membranes and they start migrating towards along the endothelial basement membrane. They start roll over to a particular position where they find to get attached to a particular position of endothelial membrane, and they start trying to induce or integrate within this basement membrane of the endothelium. So there is a picture showing the leukocytes where they moving towards that is marginating towards the endothelial membrane, and once they marginate they start rolling, that is the next middle part of the picture showing that, and then they start emigrating, that is moving away, moving towards or within in between the endothelial cells, and once they start transmigrating they are emigrated, that is they move out of the endothelial membrane. So coming to the chemotaxis, that is once these move, they are being attracted by certain mediators known as chemotactic mediators, and the process is known as attraction of this leukocytes is known as chemotaxis. So after extravasating from the blood, leukocytes migrate towards the site of injury along a chemical gradient in a process known as chemotaxis. So chemotaxis has been experimentally proved that The polymorphonucleus neutrophils or any inflammatory cells move towards the site of inflammation because of certain chemical mediators. This has been proved by a certain experiment by Boyden, where a chamber which was being utilized, which is known as Boyden's chamber, and with a pore or millimeter pore of 3 micrometers pore was being placed in between the leukocytes and the experimental fluid, and this experimental fluid constituted of the chemotactic agent, and this chemotactic agent, presence of this chemotactic agent within the test solution, after a few hours, it has been seen that after a few hours to minutes to hours, it has been seen that these new PMNs are usually attracted towards the test solution which constitutes a chemotactic agent. So this has proved that the chemotactic mediators or the chemical mediators have a major role in causing the chemotaxis. So coming to the chemokines, that is factors which bring about this chemotaxis are known as chemokines, and they are the leukotriene B4. Next, coming to the sister components of the complement system, they could be C3A, C4A, and they are the cytokines, which are the interleukins, and the tumor necrosis factors alpha, and the soluble bacterial products, that is the bacterial products which are being metabolized, and their byproducts also help in bringing chemotaxis. And then coming is this monocyte chemoattractant protein, which also helps in attracting the PMNs or the inflammatory cells towards the site of inflammatory region. Next is the eotaxin for the eosinophils and the endothelial cells. These are the chemotactic agents, also known as chemokines. Coming to the next step, that is the phagocytosis, we see that there are 3 distinct steps. First is the recognition and the attachment. Once the neutrophil has been moved away from the endothelial membrane, we see that this neutrophil starts recognizes the foreign antigen with the help of certain receptors present on it, and also because of the circulating antibodies which are present within the body fluids. And once these antibodies recognize foreign antigens and they start the exposure of the receptors, there's binding or otherwise known as attachment of the antibodies to the receptors. Once there's binding, then there's intracellular mechanisms is being stimulated by the activated receptors, and this stimulated intracellular mechanism starts showing changes within the cells. That is, they develop pseudopods which help in engulfment, or they cause the attraction of the foreign body within the cell by developing pseudopods, and this pseudopods tries to maximum cover up the foreign body, and this covered up foreign body is within the phagocyte or the phagocytic cell is known as engulfment. This stage is known as engulfment, and this engulfment is being further followed by killing and degradation. That is, the foreign body is completely within the phagocyte, and along with that there are certain enzymes, and this enzymes along within the phagocyte and the foreign antigen together are known as phagolysosome. This phagolysosome kills the degradation and killing and degradation in the phagocytosis. So there is a first step showing the recognition and attachment, where we see that the presence of mannose and scavenger receptors helps in identifying the foreign antigens, and once they are being identified, they are being coated by opsonins, that is the materials antibodies which coat the foreign antigens are known as opsonins, and these antibodies are usually immunoglobulin G, C3b and lectins. So once they are identified, that is recognized, there is ligand coated particle, the first stage, where we see to the phagocyte surface receptor, and next there are formation of the receptor clusters, and this receptor clusters starts showing signals, that is starts showing intracellular signals once because of the activation of the receptors. So once they are being engulfed, that is because of the release of the enzymes, or because of the release of the granules from this neutrophils, we see that there's degradation of this enzyme, and this degradation is being followed by killing, and degradation is being followed by disposal of the microorganisms. So disposal of the microorganisms, it could occur intracellularly, that is within the cell, or otherwise extracellularly. So Most commonly, it is occurs intracellularly and less commonly extracellularly. Intracellularly, it could be depending, or it could utilize oxygen. That is, it would be a oxygen mediated bactericidal mechanism by utilizing oxygen free radicals, or otherwise oxidative bactericidal mechanism utilizing lysosomal granules which are present within the inflammatory cells. Or otherwise, it could completely be independent of oxygen, which is known as non-oxidative bacterial mechanism. So the oxidative bacterial mechanism, which is being carried out by the oxygen-free radicals, it could be further dependent on the myeloperoxidase, or it could be independent. Myeloperoxidase, which is an enzyme which is present within the neutrophil granules. That is, as neutrophils consist of two types of granules: primary or eosinophil granules, and secondary or specific granules. This primary or eosinophil granules consists of myeloperoxidase, which is an enzyme which brings bactericidal killing. This myeloperoxidase usually brings formation of oxygen-free radicals when it acts on hydrogen peroxide. And the once it acts on hydrogen peroxide, it releases oxygen metabolites. They could be superoxide or otherwise hydroxyl groups, which bring about the killing. And once they cause the bacteria to be killed, they are being degraded and removed from the body. MPO independent mechanism, it is not usually based, it could be independent of formation of superoxides or the oxygen free radicals. Rather, it can act on the hydroxyl ion groups and results in the formation of hypohalous acids. So the MPO dependent is known as H2O2 MPO dependent bactericidal mechanism, whereas here we do not see any utilization of hydrogen peroxide. Rather, it forms singlet oxygen or hydroxyl ion groups, which helps in killing of the bacterial organisms. Coming to the oxidative bacterial mechanism by lysosomal granules, certain lysosomal granules such as which constitute alkaline phosphatases or hydroxylases, they bring about a direct oxidative damage to the foreign antigens. Whereas coming to the non-oxidative bactericidal mechanisms, so these are so-called non-oxidative because they might really not require presence of oxygen, as the lysosomal granules also contain certain enzymes which do not bring about the killing of the foreign antigens in the presence of oxygen. So they are known as non-oxidative bacterial enzymes, and these could be because of the granules other than the myeloperoxidases which are being released from the neutrophils and macrophages. And it could also be occurring in presence of nitric oxide, as this nitric oxide is being released by the endothelial cells and the activated macrophages. They are also known to cause potent destruction of this foreign antigens or bacterial organisms. Coming to the extracellular mechanisms, similar to the intracellular mechanisms which occurs by the granules as explained by the neutrophils and macrophages, granules within the neutrophils and macrophages, as they cause the damage or the killing within the cell, it occurs in a similar way even extracellular, that is outside the cell. So it is known as extracellular granule mechanism of killing by granules. So since immune mechanism is also one of the pathway in killing foreign antigens and causing its disposal out of the body, this immune mechanism, it could be cell mediated or otherwise it could be humoral mediated that causes the lysis of the organisms. So this completes the disposal of microorganisms. Next, once the foreign antigen is being recognized once they are being attracted by this bonding of the receptor with the foreign antibody, then this causes the engulfment of the bacterium. That is, that the phagocytic cells start showing a formation of pseudopods, as we can see once the bacteria moves towards the phagocytic cell because of certain chemical mediators, and this pseudopods, they start engulfing or start enclosing the bacteria within the cell. The next picture showing the enlargement of the pseudopods, that is they show enclosing the bacteria. This stage, the phagocytic cell along with the engulfed bacteria is known as phagosome, and this phagosome, it starts growing the pseudopods start growing closer to each other and result in the formation of proper well defined with the cell membrane or the plasma membrane, and this is known as complete phagolysosome or otherwise phagosome with an engulfed material. And this phagolysosome, as the phagocytes contain granules, they start once they engulf the bacteria, they it acts as a stimuli for causing the degranulation or releasing the granules out of this phagocytes, and this causes the digestion or killing and degradation of the bacterial organisms, resulting in further disposal of the microorganisms. This is what happens in phagocytosis. Coming to the chemical mediators of the phagocytosis, usually these chemical mediators are of two types. They are either derived from the cells or otherwise derived from the plasma. So they are known as cell-derived chemical mediators or plasma-derived mediators. So amongst the cell-derived mediators, they are being derived from the starting with the mast cells, basophils, and platelets, which actually produce potent chemical mediator known as histamine, which is a vasoactive amine which causes vasodilation, which brings about vasodilation, by which there is alteration in the permeability, that there will be increase in the permeability, and this histamine it acts as a potent vasoactive amine which mediates the process of inflammation. Next, coming to the other set of chemical mediators is the serotonin, which is also known as 5-hydroxytryptamine, which is being released by the platelets, and it is also similar in function to that of histamine as a vasoactive amine, bringing about vasodilation, but it is less potent when compared to that of the histamine. Next set of cells which release chemical mediators, they are the inflammatory cells which release leukotrienes, platelet activating factors. Leukotrienes, they also cause the increases the permeability by since they are being released by the neutrophils, and these neutrophils are usually involved in causing altering the vascular permeability by moving away or out of the endothelial membrane and creating gaps. So this permeability is being altered, that results in increased permeability. Then otherwise, platelet activating factor is another chemical mediator which not only brings aggregation of the platelets at the site of injury, but also helps in vasodilation, that is increases the brings about the dilatation of the blood vessel, whereby there is increase in the fluid within the blood vessel. Next are the prostaglandins. They could be various types of prostaglandins, which will be discussed in the further slides. And the other set of chemical mediators are the cytokines. They could be interleukins or the tumor necrosis factor, which are actually involved, and the cytokines also help in bringing fever, that is which is a kind of protective mechanism in inflammatory response. Next are the lysosomal enzymes, which are being released by the neutrophils, activated macrophages, as well as by the mast cells. These lysosomal enzymes cause the degradation of the microorganisms, and they might also cause the tissue damage, which also helps in removing this damaged tissue, that is debridement of the tissue by the inflammatory cells. Next are the nitric oxide metabolites and the oxygen metabolites, as discussed in the previous slides, that is formation of the superoxide by its activation of the hydrogen peroxide, and even nitric oxide metabolites, which are being released by the endothelial cells and activated macrophages, have also a role in mediating the inflammation and act as chemical mediators which bring about tissue damage. Next are the set of mediators that is derived from the plasma. They include the clotting and the fibrinolytic system, which produce fibrin split products, and the kinin system, which produces kinin and bradykinin, that brings about contraction in the smooth muscle, which aids in contraction of the endothelial membrane, which has been discussed in the previous slides. And the complement system, they produce few anaphylatoxins in the allergic reactions or any insults to the human host response, and all of these together also involved in the producing increased permeability. So other than that, there is even arachidonic acid metabolism. This arachidonic acid metabolism, it is usually mediated by the lipooxygenase or otherwise the cyclooxygenase pathway. And this further metabolites which are being released by this pathway also help in causing chemical mediation in the inflammation. So activation of the arachidonic acid metabolism by the cyclooxygenase pathway. Once the arachidonic acid is being activated, and it is being mediated by the cyclooxygenase enzyme, which causes the transformation of this activated arachidonic acid into prostaglandin endoperoxide. Since prostaglandin endoperoxidase is an unstable compound, it is rapidly converted into prostaglandin H2. PGH2. Along with that, it also releases a free oxygen radical. This PgH2 along with free oxygen radical is being further being acted on upon by certain enzymes, and this enzymes acted on in PgH2 help in also release certain other prostaglandins, which are the PGD2 and PGF2. Along with that, PGF2 alpha, all of these together form a metabolite, and they help in vasodilation. That's as vasodilation. They also bring about bronchodilation and bronchoconstriction. Other than that, they also help in increasing the or altering the vascular permeability. The next set of metabolites being released by the arachidonic acid metabolism mediated by the cyclooxygenase pathway is the thromboxane A2. This thromboxane A2, it is usually it helps in vasoconstriction by bringing the aggregation of the platelets, and also helps in bronchoconstriction, which is protective in function. The next set of metabolites are the PGI2, prostacyclins I2, and they act as a vasodilator and bronchodilator, and it helps in preventing the aggregation of the platelets, as they are so called as anti-aggregating agents. And then are the resolvins. They are the inhibitor of the pro-inflammatory cytokines, which are usually being mediated, cytokines which are being released by the T lymphocytes, so these are being inhibited by resolvins. So this is the arachidonic acid metabolism via the cyclooxygenase pathway. Next, coming to the arachidonic acid metabolism via the lipooxygenase pathway, that is, once this lipooxygenase pathway, lipooxygenase enzymes mediate the conversion of active arachidonic acid into 5-hydroxytryptamine, or otherwise known as 5-HETA, which is 5-hydroxy-endoperoxidase tryptamine. This is rapidly converted into leukotrienes A4, and this leukotriene N4, which is an unstable compound, usually is being converted into LTB4, LTC4, LTD4, as well as LTE4, and the lipoxins. This LTB4 is a compound or the metabolite which helps in mediating the chemotaxis, that it acts as a chemotactic agent by bringing the addition of the cell addition to the endothelial membrane, and also being attracting the microorganisms towards the phagocytic cell. And the next set of metabolites are the LTC4, D4, E4, and lipoxins. They are usually act as vasoconstrictors as well as bronchoconstrictors. This is the arachidonic acid and its functions in the inflammation as a chemical mediators. Next, coming to the set of complement system, that is the usually plasma-derived chemical mediators. They include the clotting system, kinin system, fibrinolytic system, which together interlink with each other and then cause the activation of the complement cascade system. And this system is usually mediated or regulated by a key factor known as factor 12, which is a coagulation factor, also known as clotting factor. This clotting factor 12A, when usually in vivo, when it comes in contact with bacterial endotoxins or fever in cases, usually this factor A is activated. But in vitro, when it comes in contact with glass or otherwise kaolin, then it's activated. But in inflammation, we see that factor 12A, that is factor 12, is activated when there is leakiness of the through the endothelial gaps, and this results in activation of 12A. So once this factor 12A is activated, it starts mediating the fibrinolytic system by causing the conversion of plasminogen into plasmin. This plasmin, it again is usually involved in conversion of fibrinogen to fibrin and also fibrin split products. These fibrin split products are usually mediate the activation of the complement cascade system. Next, coming to the other set of action of the factor 12, activated factor 12A is it mediates the clotting system. In clotting system, usually we see that there is conversion of fibrinogen to fibrin, and this fibrin to fibrin peptide products, which are also which bring about the activation of the complement system. The next set of action on is a kinin system. Usually kinin system results in the production of bradykinin, and this bradykinin is being produced by prekallikrein, and conversion of prekallikrein to kallikrein. Kallikrein is being converted to bradykinin. Bradykinin, as the name itself suggests, it is brings about the slow contraction of the smooth muscle vasculature. So this is also involved in inflammation. Thereby, once all these factors are interlinked together, or the systems are interlinked together, they cause the activation of they mediate the complement system. So the complement system is usually being So the complement system is usually being activated either of the two pathways, that is by the classic pathway or the alternative pathway. Classic pathway occurs when it is by the formation of antigen antibody complex. Alternative pathway includes there is no involvement of the antigen antibody complex. And by either of the pathways, whatever is being activated, they finally results in production of certain activated byproducts, and these are C3A, C5A, and C4B. They cause the degranulation of the mast cells and the basophils, which release the enzymes and helps in chemotaxis as well as phagocytosis. C3b, which acts as an opsonate, that it starts coating the foreign body or the bacteria and causes the and it enhances the further function of the phagocytosis. Whereas C5a, it acts as an chemotactic agent, that is, it attracts. Since it has a receptor to it on the phagocytic cell, it acts as it also helps in phagocytosis. And next is the membrane attack complex or the protein. It is also involved in the process of further inflammation, or that is the adhesion of the leukocytes to the endothelial membrane and its migration and phagocytosis. This is the complement system activation. So, coming to the classic pathway in detail, that is by the formation of antigen antibody complex, it results in the formation of C1 complex, and this C1 complex splits into C2A, C4B fragments, and this is being converted in the presence of converters into C3. This is a classic pathway by formation of antigen antibody complex. Coming to the alternative pathway, which is a continuation of the classic pathway, where we see that this C3 is being it undergoes C3 hydrolysis and results in the formation that is split into C3b and C3a fragments, and this C3b and C3a fragments further they cleave, C3b cleaves with C5 and causes its activation into C5a and C5b, whereas once this is being transferred, we see that the cells, there's formation of C5b as well as progressive C6, C7, C8 and C9, all of which we together form the membrane attack complex, and this causes the cell swells and the burst of the cell. This is the complement system activation and its function. Coming to the regulators of inflammation, usually these are known as acute phase reactants, as they mediate, they have a function in regulating the process of inflammation. Among them, it is a certain cellular protection functions that is being exhibited by the host immune system only. And then coming to coagulation proteins, they could be the coagulation factors or plasminogen factors, which help in bringing the coagulation in the inflammatory process at the site of inflammation. Next is the transport proteins. They are known as ceruloplasmin or the transplanin. They help in transportation of the proteins which mediate the process of inflammation. Next to the immune agents, they could be the inflammatory cells or otherwise the system which immunoglobulin antibodies, which help in the functions, that is the sequences of the leukocyte chemotaxis and the phagocytosis. Next is the stress proteins, that is the heat shock proteins, usually involved in elimination and that is a disposal of the microorganisms. Next are the antioxidants. They also have a primary role in inflammation by removing harmful substances from the human body. So these presence of acute phase reactants associated with certain systemic conditions such as fever. Leukocytosis is known as acute phase response. Usually glucocorticosteroids, they also help in mediate the function of inflammation by bringing an anti-inflammatory response, and free cytokine receptors also help in regulate the process of inflammation by producing certain cytokine receptors, as we have seen in the previous slides, which are being released by the T lymphocytes and which are being elaborated by the inflammatory cells. And the anti-inflammatory chemical mediators, they usually prevent the unnecessary activation of this chemical mediators and prevent the complication also of the further inflammatory process. The free cytokine receptors, they could be anti-inflammatory or otherwise pro-inflammatory. They could either mediate the process of inflammation or inhibit the process of inflammation. These are the regulators of inflammation. So coming to the morphology of the acute inflammation, it is important as a part of pathology to know the morphology under a H&E stain section, how it appears. Usually we find the pseudomembranous inflammation in certain conditions, that is, it is not a true membrane but it appears to be as a membrane formation with certain cells in it, and it is usually seen in cases of fungal infections. such as candidiasis. And coming to ulceration, that is, we see that there are defects or otherwise there is a gap in between the continued epithelial membrane, and which is also one of the morphological feature of acute inflammation. Then coming to suppuration, there is presence of few pus cells can be seen when the fluid is being aspirated from the inflammatory area, which is being observed under cytological changes of the area of inflammation. Next is the cellulitis. Because of the presence of increased fluid accumulation, we find that this process of the cellulitis can be seen. Along with that, we can see certain pyogenic bacteria also. And then in case of bacterial inflammation, we see presence of bacteremia, that is, we find certain bacterial organisms, and septicemia when this becomes toxic with the presence of certain endotoxins which are being released by this bacteria, then this results in septicemia, which shows presence of even endotoxins which are being identified in certain cultures and even certain advanced technological aids. Pyemia, we see when they which could be a pyemic abscess, that is, an abscess is being formed, that is a degenerating membrane along with certain inflammatory cells, and also formation of the granulomatous cells can be seen in case of pyogenic abscess or pyemic abscess. And the septic infarcts, that is, these once they get dislodged from their primary site, they are known as septic infarcts, which can be lodged in any circulating body fluids. This is a morphology of the acute inflammation. Next, coming to the systemic effects. So acute inflammation can be rendered or even being altered from its normal from its normal function, because in presence of fever, as there will be alteration in the number of inflammatory cells in case of fever, that is, the presence of cytokines can also bring about fever. So it is one of the systemic effect of acute inflammation. Then leukocytosis, when there's increase in the number of leukocytes, it can also bring about alterations in the acute inflammation with improper function or exaggerated function can be seen, such as in hypersensitivity is one of the exaggerated inflammatory response exhibited by the host immune response. And coming to the lymphangitis and lymphadenitis, that is draining of this inflammatory cells into the lymph nodes or otherwise into the lymph, it's known as lymphangitis, lymphadenitis, and this is one of the systemic effect, and which could be a kind of complication and acute inflammation. Next, coming to shock, that is when there's fluid imbalance in the body, then it could also result in shock of the patient, which would be one of the systemic effect of acute inflammation. Coming to the fate of the acute inflammation, it could either resolve completely, that is, it could completely bring healing in the patient, otherwise it could also bring suppuration by formation of pus discharge, where the unnecessary cells are being discharged out in the form of suppuration, and otherwise this presence of acute inflammation in further episodes or progressive nature can result in chronic inflammation. Coming to the chronic inflammation, it is usually defined as a prolonged process in which there is tissue destruction and inflammation which occurs at the same time, that is, occur simultaneously. That is, the destruction as well as inflammation occur simultaneously, and it is usually a prolonged process which is exhibited in a human system. Usually the time course of this chronic inflammation is usually greater than 48 hours after the attack of the inflammatory agent, that is the agent which has induced its inflammation. And the cells which are included are the mononuclear cells. They are primarily the macrophages, and the next line of cells are lymphocytes and plasma cells. Coming to the cause, usually chronic inflammation, it is usually because it could follow the phase of acute inflammation. When it is not being resolved, then it can result in chronic inflammation. Otherwise, if the acute inflammation shows activity of acute exacerbations, that is, it could show for phases of relapse and recurrence, then it could also result in chronic inflammation. Otherwise, chronic inflammation, it could start de novo, that is, when the inflammatory agent is usually harmful and it is more exaggerated, which cannot be resolved by the acute inflammation, then chronic inflammation is being elicited. Coming to the general features, whatever the features are being found. So the mononuclear cell infiltration, it is usually characterized with the infiltration at the area of chronic inflammation. We see presence of phagocytes, lymphocytes, plasma cells, neutrophils, and these cells are being driven to the site of inflammation with the help of chemotactic factors or the chemokines, which help in movement, whereas tissue destruction or necrosis is usually seen in areas which has been destroyed by the microorganisms. These are being removed by the host immune response. Necrosis, which is being performed by the enzymes of the cells on human body, where they try to debride the area completely. Coming to the proliferation changes, as chronic inflammation, it is a long-term process and it's for a longer duration. So other than debridement, it is also followed by healing, where there will be fibrosis, that is for proliferation of the fibroblasts, collagen tissue, and formation of granulation tissue, which helps and brings about proliferation of certain vasculature and the extracellular matrix components, and this tries to completely result in fibrosis or scarring, which is also known, which is a phase of healing. So these are the general features which we see in chronic inflammation. Coming to the systemic effects, usually in chronic inflammation, since it's for a longer duration, it is usually associated with fever, and anemia is usually associated in cases of chronic inflammation. There's increase in the number of leukocytes because of its host immune mechanism, which is being exaggerated because trying to protect the human from the inflammatory cells and the foreign antigens. So the number of leukocytes are being increased, which is a kind of protective mechanism, and the ESR is also usually elevated in case of chronic inflammation. Amyloidosis, usually in long-term cases of chronic inflammation, we see that there's development of secondary or systemic amyloidosis, which is an AA type of amyloidosis. Coming to the types of chronic inflammation, usually it is broadly classified into specific and non-specific. It is usually known as non-specific because there is no specific irritant which is present. Rather, it is a commonly seen with presence of inflammatory cells, and there is no specific etiological agent when observed, when it is being observed to drive out the agent which has caused its reaction. But whereas this occurs in a non-specific, and an illustration of chronic myelofibrosis and chronic ulcers can be given, which have no definite cause for occurrence of it. Whereas in specific, we find in cases of tuberculosis or syphilis, as there's presence of the etiological agent which can be observed and with proper signs and symptoms in case of specific chronic inflammation. Broadly describe it into histologically, it is classified into chronic non-specific and chronic granulomatous inflammation. In chronic non-specific inflammation, histologically we observe that there are no specific agents which can describe why the chronic inflammation has usually started. Whereas in chronic granulomatous inflammation, we can see that there's proper granulation tissue formation. Along with that, we can see certain microorganisms. We can see certain microorganisms which have actually induced this granulomatous inflammation. It is seen in tuberculosis, leprosy, which are all granulomatous inflammations. And a chronic non-specific inflammation, an illustration of chronic myositis or lung abscess can be given. So these are types of chronic inflammation. So next, coming to the differences in acute and chronic inflammation, usually we find that the causative agent, it is usually caused by bacterial pathogens or any injurious stimuli. And whereas in chronic inflammation, we see that this persistence of the agents which have caused the acute inflammation, which have not been degradable, the pathogens are not being eliminated completely, or otherwise persistent viral infections, foreign bodies or autoimmune reactions can also cause a chronic inflammation. Coming to the major cells, as already explained, neutrophils are the first line of cells which are primarily involved in acute inflammation. Followed by them is the basophils, eosinophils, and the other mononuclear cells. They could be the lymphocytes, plasma cells, or macrophages. Whereas in chronic inflammatory cells, we see that the first line of cells are mononuclear cells. They could be monocytes, macrophages, lymphocytes, and plasma cells. Next, followed by them is the fibroblasts, rarely. Then the mediators of the acute inflammation, and they are the vasoactive amines and eicosanoids, that is the agents or metabolites of the arachidonic acid. Since it's a derivative of eicosanoic acid, it is known as eicosanoids. And whereas the primary mediators in chronic inflammation, they are the mediators which are being released by the inflammatory cells, and they are the interferon gamma and the cytokines, growth factors, and as well as the reactive oxygen radicals or the species. Coming to the onset, it is usually immediate in nature, and whereas it is delayed in nature in chronic, and the duration of the acute inflammation, it lasts for a shorter period, that is for few days, whereas we see in chronic inflammation, the duration it could last for months, years, or weeks together. And the outcomes, usually acute inflammation, it resolves completely. Otherwise, it might result in formation of abscess, or if not healed completely, it could transform into a chronic inflammation. Whereas chronic inflammation results in destruction of the tissue, results in healing, bringing about fibrosis, and also causes necrosis, that is debridement of the cell destruction area. There's a difference of the acute and chronic inflammation. Next, coming to the granulomatous inflammation, as it is also one of the sequelae of the acute inflammation and the chronic inflammation. So for that, we need to know how a granuloma is formed and how it is being defined as. Since granulomatous inflammation is chiefly composed of the formation of granulomas, so it is important to know how a granuloma forms. So a granuloma is usually described as a circumscribed tiny lesion. That is, it is properly circumscribed in area, and it is a tiny lesion which usually measures about 1 mm in diameter or less. And this granuloma, it consists of modified macrophages, which are also known as epithelial cells, since they resemble the epithelial cells, which give an appearance of an epithelial cells. They are known as epithelial cells, and these epithelial cells are present in the center, and peripherally they are being surrounded or circulated by a presence of lymphoid cells. That is, the cells which are being derived from the cell-mediated immunological response. This is for granuloma. Coming to the granulomatous inflammation, it is being described as it is a pattern or a type of chronic inflammation with the presence of granulomas, which usually are 0.5 to 2 mm in diameter. And these granulomas are again they are collections of modified macrophages, that is epithelial cells. These modified macrophages could be histiocytes or the macrophages, and they are also composed of giant cells. And these giant cells, they are again further formed by the fusion of the macrophages, and these are being surrounded by the rim of lymphocytes, which are of cell-mediated origin. So this is a granulomatous inflammation. Then how? There are two types of granulomas which are being formed. That is, it could be foreign body granuloma or immune granuloma. That is a granuloma which is being formed because of the granuloma which is being formed because in response to the foreign body, or otherwise which could be a protective in nature for the human, which is being induced by the human host response and results in immune granuloma formation. Coming to the composition, that is epithelial cells, that is a modified macrophage cells which give an appearance of an epithelium, which usually has a slender or otherwise slippery nucleus with pale and lightly stained eosinophilic cytoplasm. This is an epithelial cells. And next comes the multinucleated giant cells, that is the macrophages fuse when they fail to remove the foreign antigen. They fuse the adjacent cells and result in formation of multinucleate giant cells, and this results in the formation of multinucleate giant cells in granuloma. Next comes to the lymphoid cells, which are being derived from or originated from the cell-mediated host immune system. And there's also necrosis, that is the necrosed tissue can be seen, which is being a degraded tissue, and followed by this is a fibrosis, which represents the healing phase of the granuloma. So this is a composition, that is the contents which are being seen in a granuloma. Then how a granuloma is formed? Granuloma is usually formed when there's any cell injury and there's failure to digest the foreign antigen. Then this foreign antigen, it induces a weak acute inflammatory response. This weak acute inflammatory response, this is being followed by the engulfment of the macrophages. This when there's failure of this engulfment by the macrophages and the injurious agents usually persist in nature, they might be either mediated by the host immune response, that is, it could be T cell mediated host immune response could be activated, or otherwise there could be poorly digestible agent, that is the foreign antigens are not removed completely. Then either of the two stimulated sequential steps results in activation of the CD4 cells, which are the T lymphocytes, and these CD4 cells are usually cause the activation of the monocyte chemotactic factor. And this, once the monocyte chemotactic factor is being activated by the CD4 cells which have come at the area of this granulomatous inflammation, then they cause the accumulation of the T cell proliferation. This macrophages cause the accumulation of the T cell proliferation. And this macrophage further, it also causes the activation of the tumor necrosis factor alpha. Since the activated macrophages constitute granules of this macrophages constitute the presence of tumor necrosis alpha, which causes the transformation of this macrophages into epithelial giant cells. This gets activated and starts showing its effect by forming epithelial giant cells, that is the modified, these are the modified macrophages, or otherwise it may cause also the fibroblastic proliferation and results in cytokine secretion, which results in systemically, it causes a fever and also causes tissue destruction and results in formation of granuloma. This is the how the granuloma is formed and how it results in granulomatous inflammation.